Madam Sandhya ma'am, Sandhya Gupta ma'am.
Yes, yes.
Ma'am, now it's 45, almost 310 members are available online. So YouTube started live.
Okay.
So now you may proceed. Yeah. Good evening.
Good evening to everyone. Namaskar. We are going to start this 5th webinar conducted by Indian Society of Psychiatric Nurses. I'm very happy to see all of you here, and I welcome all the EC members, the President, Dr. Edamma, and the General Secretary, Dr. Radhakrishnan. I welcome everyone here, Madam Lakshmi Nair from USA. I welcome you. So I start the session today with prayers that we are working very hard in our profession, and God should bless us to continue working hard and continue learning forever. And we appreciate all of you have joined us today for this some function. And I respect everyone to mute their mic throughout the presentations and kindly use your chat box to put any questions and Q&A. Please write only the questions there, and we will take up the questions as the time permits. So I request Dr. Sumiti to kindly show the slide for the guest of honor, Dr. Edamma. We'll start with the blessings of the President.
Yeah.
Please show the slide of Madam. Hello, Dr. Subiti.
Yes, ma'am. Is it visible, ma'am?
Yes, yes, visible. So we have Dr. Edamma here. She's a pioneer in mental health nursing in India. She is the president of Indian Society for Psychiatric Nursing, and she is ex-professor and HOD of Department of Nursing at NIMHANS, Bangalore. Presently, she is Nodal Officer, National Consortium for PhD Nursing by INC in collaboration with Rajiv Gandhi University, Karnataka. From 2006, she has guided various students for PhD and Masters. She's member of Nursing Education Committee, Formulations Committee, INC International Contribution. She has many international contributions. One of them is she has served as resource person for BP Koirala Institute in Dhahran, Nepal. She has been awarded Best Outgoing BSc student 1970 from Osmania University. She is Silver Jubilee Award from NIMHANS for 25 years of service. Golden Jubilee Service Memento from INC. She's guided all of us sitting here for many of our activities. She's member of various committees at the government level and international level. I welcome you, Dr. Edamma, for your blessings for this webinar.
Thank you very much, Sandhya Gupta. My blessings are there to my students and great-grand students also. I'm sure the inspiration that I have given to others is percolating through generations. And I'm very happy about it. And I'm so happy to see Lakshmi here. And I think this webinar should give us how independently nurses can work And we are looking for more and more avenues for independent practice in nursing in various specialities. And let us listen to Lakshmi. All the best, Lakshmi, to you.
Thank you, ma'am.
I request Sumiti madam,
Yes, ma'am.
we'll just wait for the instructions. I request Dr. Bala to kindly give us information for Indian Society of Psychiatric Nursing. And those of us who have not been updating of what ISPN is doing for us, maybe he can throw some light. So Dr. Bala Murugan is the Joint Secretary of ISPN. I welcome you, Dr. Bala.
Thank you, ma'am. And hope the slides are visible now, ma'am.
Yes.
Yes, ma'am. So we are Indian Society of Psychiatric Nurses. So this society was started in the year 1991. It is a registered society of mental health nurses and allied health professionals registered under Societies Act. This society is meant for professional and scientific development in the field of mental health nursing. As on today, we have life members around 2,413 who are all completed their MSc in psychiatric nursing as well as DPN. And we have other membership called associate life members here, 124. They are non-mental health nursing professionals, and 12 fellows are awarded as of now. So what are we doing? So basically, we one of our objective is dissemination of the knowledge and expertise. So we do it with the annual conferences. These are a few last year's conference. 21st we did in Narayan Nursing College, and 20th we did in University. And then upcoming conference is in Goa. That is 22nd conference. We are planning it from 24th to 26th February 2023 at Indian Institute of Nursing Education, Goa. The theme is role of nurses in promoting mental health lifespan approach. I request all the members to visit our website and register for the conference. I take this opportunity to invite all the members to register as a delegate for the conference, as well as we have an opportunity to present your posters and papers in the scientific forum. So I request all the members to make a note of it. You can visit our website for the further updates. Then we publish a peer-reviewed UGC care listed journal called Indian Journal of Psychiatric Nursing. We're stepping into 17th year and partnered with Walter and Kluwer International. So peer-reviewed, and as I told you, it's listed under the UGC care list. And we are in the process of getting indexed in the PubMed, and soon we'll achieve this milestone also. And please visit our website ijpn.in, and please submit your manuscript which is related to psychosocial mental health nursing aspects. And we have an MOU with ISPN Psych International. It was finalized in the year 2020 with the objective of collaboration for sharing knowledge, research, and advancement, mutual sharing of information of conferences, publications, resources, as well as CNE and CPD points. Not only this, during the time of COVID pandemic, ISPN is joined hand with Indian Nursing Council, and we did a telephonic consultation, especially for the nurses who are in the battlefield. So mainly to reduce their stress and burnout. Also, we have a learning center called ISPN Learning Center. It runs in Moodle platform. Right now, we have one module on mental status examination, which has 32 videos of that 68 minutes. You can visit our website to get the details about this learning center. And we have a YouTube channel right now. This meeting also in YouTube Live, where you can see the learning videos as well as materials. It's free access. Please subscribe to this YouTube channel for the few regular updates. During conference, we recognize the people who are in good and research in the name of Sarla Kapoor Young Scientist Award, as well as the seniors will get awards like ISPN Fellowship, and best papers and best posters are awarded every year during the conference time. Why should I become a member? Those who are mental health professionals and not yet member, these are a few benefits I would like to share with all of you. One is, as a member, we can have a special registration fee for conferences, and we can avail 50% concession in the journal subscription. We can contest an Young Scientist Award in the annual conference. We can organize CNE at your own region with the support of ISPN. After 10 years of Prime member, you are eligible to apply for an ISPN fellowship. How to become a member? Please visit our website, ispnindia.org. Click this button called Become Member. Select the category as a life member or associate life member. Fill the necessary details. Pay the fee online. Email your photo and biodata to info@ispnindia.org. You will receive your membership card and badge in a couple of weeks. What are the future plans? We plan to have a research grant for mental health nursing research and strengthening the regional presence of ISPN, as well as increase the number of executive committee members, revision in the structure and function of ISPN. These are our future plans. Please reach us in this email ID, info@ispnin.org. Visit our website, ispnindia.org, for regular updates. So I take this opportunity to thank on behalf of the pattern, president, secretary, and all the EC members. Thank you all for joining this international webinar, and wish you all the very best. Thank you, ma'am. Ma'am, over to you, ma'am.
Thank you so much, Dr. Bala, for doing this for us, that everybody knows what ISPN is doing in such a short time, has done wonderful work and activities in the field of mental health. Now I request Dr. Sumiti to kindly give us the slide for the speaker. Madam Baibi. No, Madam Baibi. Oh, yes. You are right, Sumiti, you were showing the right slide. I request Dr. Jayanti to please initiate. Sumiti, you were right.
Is it visible, ma'am?
Yes.
I invite Dr. Jayanti, ma'am.
Yeah, it's my great pleasure to introduce Dr. Sandhya Gupta, who is unfolding the theme of today's webinar. She is currently health consultant and lifestyle coach, formerly associate professor and principal, College of Nursing, AIIMS, New Delhi. And she is currently chief editor of our ISPN journal. And she has total 41 years of experience. And she is member of National Nursing and Midwifery Commission Committee, chairperson for the Committee for Development of Nursing Informatics for Nurses for Ministry of Health and Family Welfare, and chairperson for nationwide training for capacity building of nurses for first wave, second wave, and third wave of COVID-19 pandemic, and chairperson for Omicron and post-COVID-19 sequelae. And she is one of the national trainer in substance use disorders, and she has many honors and recognitions to her credit. She is decorated with President's Gold Medal, WHO Fellowship to Australia, Fellow of Indian Society of Psychiatric Nurses, Prashanti Award, Best Research Work Award of AIMSonians of America, and she is PhD Guide for National Consortium. And she has total 145 publications in various national and international journals. And she has written a book and modules for WHO and Government of India. Over to you, Madam, Dr. Sandhya.
Thank you very much, Dr. Jayanti. I would like to thank ISPN for giving me this opportunity to conduct this webinar and for unfolding the theme. All of us know that alcohol is a big problem all over the world. And many times we think it is part of normal life. It is very important for us to know that there is something called as alcohol use, and something called as misuse, and something called as harmful use, and something called as dependence. Now, many times we discuss these things and we are worried about dependence. By the time a person who has been using alcohol comes to us, the person has already undergone a lot of damages to their various organs. One problem which they face is binge drinking. Now, binge drinking is never taken as a disorder. It's never taken as a problem. Because if there is a holiday and you are in holiday mode, and if you go for binge drinking, there is no problem. It is accepted. So when something which is going to be very seriously harmful, and if it is accepted as normal part of life, it can be very, very dangerous. So today we are talking about binge drinking disorder, which is one of the neglected areas, even in addiction area.
Can I
Thank you.
start?
Yes, yes.
Binge drinking is a serious, but binge drinking is the most common and costly pattern of excessive alcohol use. It is defined as consuming 5 or more drinks on an occasion for men, or 4 or more for drinks on an occasion for women. A standard drink is defined as 10 grams of pure alcohol, which is equivalent to a shot of whiskey or other spirits at 40% alcohol by volume. Blood alcohol concentration is the percentage of alcohol in blood when one drinks. In India, when driving a vehicle, the permissible blood alcohol content is set at 0.03 per 100 ml blood. That works out to 30 milligram of alcohol per 100 ml of blood. National Institute on Alcohol Abuse and Alcoholism defines binge drinking as a pattern of drinking alcohol that brings blood alcohol concentration to 0.08% or 0.08 grams of alcohol per deciliter or higher. For a typical adult, this pattern of alcohol misuse corresponds to consuming 4 or more drinks for female and 5 or more drinks for male in about 2 hours. Research shows that fewer drinks in the same time frame result in same BAC in youth.
So the latest National Family Survey data between
2019 and
2019.
2021 report a decline in alcohol use compared with previous surveys. However, this decline does not align with alcohol sales data in India, which shows an increase in sales. The most plausible reason for this mismatch is that alcohol use in India is rising among those who use alcohol heavily. The decrease in prevalence of drinking does not mean that globally there are fewer drinkers currently, because the world's population has increased. In fact, in absolute numbers, there were about 91,000 more women who drank alcohol in 2016 as compared with 1,000, despite a worldwide 5% decrease in current drinking prevalence from 37.3% to 32.3%. Among men, the prevalence in current drinking decreased by 4.3% from 57.9% to 53.6%, which globally amounts to an increase in absolute numbers of 245,000.
Now 53%.
That alcohol-related deaths would lead to a loss of 258 million life years between 2011 and 2050. The study has found that after adjusting to tax receipts from alcohol sale in India, the economic loss from adverse effects of alcohol consumption would touch about 1.45% of the gross domestic product, For comparison, a government's annual expenditure on health is about 1.1% of GDP. Therefore, it clearly shows that alcohol harm costs more than the entire health spend. In a survey, about 50% of all the alcohol consumed by adults and about 90% of all the alcohol consumed by young people is consumed during binge drinking sessions. Data given by CDC. There are dangers due to binge drinking. It can lead to alcohol poisoning in many cases. Complications of alcohol poisoning can result in choking, rapid vomit, severe dehydration, hypothermia, seizures, heart attacks, brain damage, and even death. A myth that once in a while binge drinking is not unsafe has to be removed from the mind of people. Binge drinking is never safe. Recovery requires to cut back on binge drinking and avoid potential dangers of alcohol overdose. Quitting binge drinking requires detox program and change in one's lifestyle. Time has come to take lead in these services related to people suffering with alcohol and drug abuse. Experienced nurses in alcohol and drug services can offer valuable resource in the delivery of clinical supervision to other staff within the service. The nurse can provide holistic perspective when reviewing clinical cases, and given their training, will be mindful of biological, psychological, and social aspects of care. Thank you very much for your attention.
Thank you, Sumiti. I request you to give us the slide for the next speaker, Madam Baibi. She will tell us the role of nurse practitioner in a program which is meant for people coming with the problem of substance use. So what a nurse can do in such type of specialized facility. So Ms. Jacqueline Baibi, she is a psychiatric nurse practitioner, board certified, works in recovery innovations in Urgent Psychiatric Center in Phoenix, Arizona, USA. She is a nurse practitioner based out of Peoria, Arizona. Her specialization is psychiatric mental health. She's currently working in urgent psychiatric care facility and also doing doctorate of nursing practice with research interest in evidence-based best practice in treating individuals with serious mental illness. Thank you, Sumiti. So she is with us with the recording. You know, it's early morning in USA. Please mute your mic. I request everybody to please mute your mic. Yes, Sumiti ma'am. We can't hear anything, Sumiti ma'am.
Hello everyone, my name is Jackie Baibi. I'm a psychiatric mental health nurse practitioner, and I would like to take a few minutes to discuss the role of the nurse practitioner within the healthcare setting. The role of the nurse practitioner was originally developed in the United States around 1960 in order to address healthcare shortages, especially within underserved populations and rural communities. The role of the nurse practitioner originally developed in the primary care setting, but has since expanded in both a specialty practice and clinical practice settings. For example, clinical specialties include women's healthcare, primary care, acute care, pediatric care, psychiatric mental health care, and even anesthesiology. Furthermore, practice setting have greatly expanded, and nurse practitioners can be found in virtually every patient care setting, ranging from the intensive care unit to long-term care, outpatient care, and even owning their own independent practices. The scope of practice of nurse practitioners include assessing, diagnosing, and treating patients with various acute and chronic health conditions, and encompasses developing plans of care, ordering diagnostic testing, and ordering appropriate medications to address symptoms. The nurse practitioner also focuses on health promotion and disease prevention, and are strong advocates of patient education and having patients be active participants within their own care. Research has demonstrated that nurse practitioners are high quality and competent providers on par with other providers such as physicians. And furthermore, nurse practitioners tend to have very high patient satisfaction ratings, which is attributed to the philosophy of nursing, which teaches us to approach our patients from the perspective of them as a holistic person, whereas the medical perspective tends to be more pragmatic and problem-focused. The role of the nurse practitioner, also the role and the scope of practice and the practice authority of nurse practitioners vary also by state within the United States. For example, in Arizona, we have full practice authority, which means that we have full prescriptive authority, and also have the ability to own and operate our own independent practices. Other states in the United States, such as Texas and California, are more restrictive, which means that they may require having a collaborating physician, and they have restrictions on which medications they're allowed to prescribe. However, regardless of which state nurse practitioners choose to practice in their daily clinical practice, they operate with autonomy and independence. Most importantly, the role of the nurse practitioner is invaluable in providing high quality, competent, and accessible care to individuals. And it also is, nurse practitioners also are and will continue to be innovators and leaders within the healthcare community. I appreciate you all taking the time to listen and your attention, and I hope that you all enjoy the rest of the webinar. Thank you.
Actually, we received this video at the last minute as she could not join us. And I'm sorry for that, audio was very weak. I request Dr. Sumiti to kindly show us the slide for the next speaker. Yeah, so we will, I would like to introduce Ms. Lakshmi Nair. She has given very brief CV here. She is a psychiatric mental health nurse practitioner, board certified mental health nurse. She has been working with Mind 24/7 Urgent Psychiatric Center, Phoenix, Arizona, USA. She's also adjunct faculty at SUNY Stony Brook, New York, USA. PhD scholar in nursing and health innovations at ASU. Other affiliations, she's also vice president of Arizona Indian Nurses Association. She has interest in trauma-informed care, substance abuse disorder, medication-assisted treatment, severely mentally ill population, co-occurring disorders, treatment, nursing research. She did her BSN from Amrita Institute from Kerala and she has done her post-graduation from NIMHANS, Bangalore. I welcome you, Lakshmi. We are so proud of you. And I'm so happy that you are so experienced in the area of substance abuse. And it's early morning. She has come after night shift, and she is here with us to tell us about her experiences of dealing with binge drinking and how a nurse practitioner can play role as frontline practitioner. Thank you so much. I welcome you.
Thank you, Dr. Gupta. Thank you very much for having me. Am I
Please.
audible?
Yeah, please share your slides and we will see how it's going.
Yep. Is this visible?
Yes, yes.
Okay, perfect.
Just make it in presentation.
Yes.
Presentation mode. Yeah, thank you.
If someone can keep a tab on people that are coming into the waiting room, I've been just allowing, people who have been joining in. So if we
No.
could have
Yeah,
some.
if you don't allow, you please continue presentation. We will do that.
Yeah. Okay, so. Okay, it's still visible?
Very much.
Okay, perfect. I am very honored to be here today. This is wonderful to have such a great group of participants. More so, I'm just honored to be in the presence of my wonderful teachers. Dr. Redama ma'am, Dr. Nagarajaya sir, Dr. Ramachandra sir, all of them who taught me, gave me a good taste of what it means to be a psychiatric nurse. And, after having moved to the United States, I explored further into advanced nursing practice. And I've been practicing as a nurse practitioner in psychiatry here in the United States, in New York, as well as in Arizona for the past 5 years. I've been a psychiatric nurse since I graduated from NIMHANS, and I've continued to work in different areas within psychiatric nursing in the United States. I moved, in fact, to the United States right after I graduated from NIMHANS. So, this is where much of my practice has been. So I want to share some specific info that you can take away, take home, take to your clinical practice. This doesn't require for you to be an advanced nurse practitioner. These are techniques and communication skills that you can carry on into and utilize in every sphere of nursing, if you would call it that, not just in psychiatric nursing. Applications of competencies that are being discussed here is adapted from motivational interviewing. The brief intervention that we are going to share today is adapted from the trans-theoretical model of change, which is very fundamental to motivational interviewing. So you'll see how practical this is and how you can use this on a day-to-day basis while having conversations with people in your family, people who struggle with substance use disorders that you come across in your friendship circle. So this does not require for you to be, an advanced practice nurse, but having psychiatric nursing skills definitely helps. So Dr. Sandhya Gupta has already given you some wonderful statistics, so I don't think I need to go too much into detail, but I added this just in case if that wasn't something that was discussed. So global burden of disease, the 2020 report estimated that about 1.38 billion people consumed harmful amounts of alcohol. Not just drinking alcohol, but harmful amounts of alcohol. And among that, this is global report, so 1.03 billion were men and 0.3 billion were females. And among, people who consumed, about 59.1% of people who consumed unsafe amount of alcohol, the ages between 15 and 39 years. And among those, almost 77% were men. So we generally see the gender bias, among men and women in terms of, and there is a social construct of acceptability of drinking among men versus women across the globe. This was presented in Lancet. It's an excellent article for anyone that's interested in reading. This is an analysis of the global burden of disease report. We also do see from this analysis that about 15 to 29-year-old folks, the high risk alcohol is implicated in about 86% The entire harm from alcohol use, about 3.6 million substance use associated death, right? Among that, about 86% in young adults. So we see how harmful this is among young adults. Now, Dr. Gupta also did a great job with presenting Indian statistics, and I think that covers it all, so I don't want to waste too much time on this. But we do know that about, this is a little old, but it's only grown in the last 10 years. About 33% of all road traffic incidents were attributed to drunk driving. And more so, binge drinking disorders have played a big role in drunk driving deaths. This is only further worsened by about 38% between 2010 and 2017. Now, this is a bit of a busy slide, but I wanted to include this table of a systematic analysis. It's a beautiful analysis of citywide comparison of alcohol use and complications arising from alcohol use, which varies widely between 23% to all the way to 45, 50, 56%. So this is a nice breakdown, and you'll see the metropolitan cities do have a higher incidence, obviously, because of various factors: alcohol availability and acceptability and social use, and that progresses to use disorders. Now, we saw some significant changes in the demographics within alcohol use and binge drinking patterns during COVID. There is mixed data on how COVID has impacted alcohol use disorders as well as alcohol-related withdrawal syndromes. So initially, when COVID hit, everything was banned, including alcohol in many countries, while we had small percentage of countries which kept alcohol as a necessity and seeing the importance of preventing complicated withdrawal among substance users and alcohol addicts. So we did see a sudden surge in complicated alcohol withdrawal during the first initial alcohol ban. We also did come across about 6 cases, if I'm not wrong, of suicides that was reported in my home state of Kerala, which led to another ethical issue of managing withdrawals. And it's at that point, the government, from what I read in one of the reports that was presented, the government was advising psychiatrists and other physicians to write a prescription for alcohol so they can, continue to manage and prevent acute complicated withdrawals, which raises a huge ethical issue. If you can think about, having doctors write a prescription for alcohol and what an ethical issue that could be, because, just treatment for acute complicated withdrawal was not something they can handle during a pandemic of this magnitude. So immediately post-lockdown, we did see increasing number of alcohol intoxication cases presenting to emergency departments. Countries across, across US, across European countries, the demographics have varied. So if you're interested in looking at more details, I will be giving you the references in which, you'll be able to go in and see the demographics across the countries. We did, however, notice that there was a huge surge in addiction-related behaviors after the initial lockdown. There is overall an increase in alcohol use and cannabis use and tobacco use and screen time, and now a new emergence of behavioral addictions, which we should be on the watch out for, and binge eating disorders that have been in rise post-lockdown. So these are some of the sequelae of COVID and the lockdown that we should, as psychiatric nurses, be aware of and should be on the watch. Now, as we just discussed, there's been mixed evidence. There's increase in certain countries and decrease in certain other countries, but overall consensus is that alcohol-related harm has increased during COVID. There's more solitary drinking, there's increase in binge drinking episodes, and there is increased number of relapses and reduced quit attempts. And we know that the psychological impact of confinement, right, during COVID That's definitely played a big role in how the countries have handled policies related to alcohol during lockdowns and post-lockdown has definitely made a big impact. We already saw this, so I'm not going to repeat it. So one drink is 12 fluid ounces of regular beer, and it varies from 8 fluid ounces of malt liquor to 5 ounces of table wine, and then to hard liquor, which is about 40% alcohol. It's just about 1.5 fluid ounces, which is classified as one drink. What's low risk drinking limit? Not more than 4 drinks in any given day, not more for men, and not more than 3 drinks in any given day for women. And if you look at a week span, not more than 14 drinks and not more than 7 drinks for women. 14 for men and 7 for women. Now, it's important to remember that this limit, which is identified as low risk drinking pattern, is only for adults with absolutely no underlying health risks. They should not have diabetes, no hypertension, no underlying heart disease, no underlying mental health problems, none of that stuff. No underlying health risk, and only for people over 40 years of age. For folks under 50, folks between 15 and 39, there's absolutely no health benefits to drinking alcohol. Very, very, very important to remember this. And for people above 40 and under 60, there is some benefits, as we know, about 2 drinks, right? Like 2 drinks a day, 3.4 ounce glasses of red wine, which is small amount of alcohol for people who have absolutely no health risks between 40 and 60 years. That's the only age group that is safe to consume alcohol at that minimal amount. And that is supported by some data that reduced, that decreased, minimal amount of drinking does reduce the risk for cardiovascular disease, stroke, and diabetes. So this is often misconstrued, this idea of healthy limits of drinking that could potentially help my heart. These are some of the excuses that you will see in folks who are getting into alcohol and probably getting into that higher risk limit. So it's very important for us to be clear. There's absolutely no health benefits for people above 60 years of age or for people between 15 and 39, okay? Now we have different levels of drinking severity, abstinence to all the way to dependent drinking. And the categories between that is safe drinking, harmful drinking or abuse, risky, hazardous drinking, and dependence to alcohol. Now, there's only slight differences among these definitions, but it's also worth knowing what it means, these terminologies. Harmful drinking pattern basically starts resulting in physical and psychological harm to the individual or society. That's the way we define, harmful drinking levels. Now, hazardous drinking pattern is defined as a quantity or pattern of alcohol consumption that places individual at a risk for higher adverse health events. When the organ starts getting affected, that's where we start calling it hazardous levels. And alcohol dependence, as we all know, it's a cluster of behavioral, cognitive, and physiological phenomena. We have criteria, that we follow according to ICD-10 as well as DSM-5 across countries. We have the criteria that we follow, which includes the things that we normally use as criteria, which is strong desire to consume alcohol, difficulty in controlling the use, persistence of use despite harmful consequences, higher priority, their life starts revolving around alcohol, and they start going down on other activities and obligations, and there is increased tolerance. We talk about physiological dependence and withdrawal states. We're all probably very familiar with that. Okay, so now we also saw the definition, but I just want to review this. 5 drinks for men, 4 drinks for women in the time frame of 2-hour period. That was the original definition given by National Institute of Alcohol Abuse and Alcoholism. Now they revised this definition to include the concept of the 2-hour time frame, which is a new concept of 2-hour time frame, which was updated in 2004. And then they also included the concept of BAC within the blood alcohol levels within the definition. So within the definition, they added the blood alcohol level, which is defined as the level of 0.08, is enough, which is basically, you know, most people start achieving that level within about 3 to 4 drinks. And some people even achieve that level within a drink or two. So depending on individual metabolism of alcohol, some people achieve the blood level very quick, and some people can drink 7 or 8 drinks before they, you know, reach that blood level. But in general, the consensus is that around 3 to 4 drinks, you'll start seeing the blood level, and you will also start seeing impairment, such as difficulty with coordination. You know, it starts going beyond the euphoria. You start seeing some of the unsteadiness and the motor coordination, and the cerebellum starts getting affected with, you know, from alcohol, which is one of the reasons why we consider that as our cutoff limit. Surprisingly, you will see in the US, legal drinking limit is up to 0.1. So, which is ironic, you know, you're binge drunk, you know, you have the blood level, but you're still not illegally drunk. So there's a fine line between that. You know, so it's very tricky among individuals. And the safest thing is don't drive when you're drunk. That's the safest measure, because you just don't know how quicker your cerebellum is going to get affected with alcohol. Okay, hazards of binge drinking go very hand in hand with what alcohol can do in the long run. But we know that binge drinking is associated with a myriad of health and social problems. It has been associated with great risk of injury and death, antisocial, illegal behaviors such as drunk driving, assault, stealing, damaging property. And making matters worse, binge drinking across generations has also been shown to predict problem gambling behavior. Binge drinking among women, young women, places them at higher risk for sexual assault. So we're all placing, you know, none of us are immune to it. So people are placing themselves to higher risk for health and you know, health hazards and injury and even death. Now, this is also a slide demonstrating the different organ damage that can happen from alcohol and binge drinking. That varies from cardiac arrhythmias, cardiomyopathy, hypertension, ischemic heart disease, to ischemic and hemorrhagic stroke. Cancers affecting different parts of the body, you know, esophageal cancer, oral cavity cancer, liver cancer, pancreatitis, cirrhosis, myopathy and acute respiratory distress syndrome, pneumonia, gastrointestinal problems, colorectal cancers. So it affects every single part of the body, and we know that this is, you know, supported very well by the research that we know over you know, 5 or 6 decades or longer. Now, I want to spend a few minutes just on the neurocognitive problems from alcohol, and this data is particularly focused on young adults. Over 30 neuroimaging studies have been published on the topic of alcohol-induced changes on the developing brain and binge drinking pattern just in the last decade. So binge drinking and withdrawal and hangover symptoms have been associated with the greatest amount of neural abnormalities during adolescence, particularly the frontal, parietal, and temporal lobes. Hippocampus has been particularly of interest because of memory consolidation. People tend to forget what they did the previous nights because it affects the memory consolidation. Often people go into blackouts and they don't know what they did, and that is attributed to how hippocampus gets affected. We also do know that the smaller, the gray and white matter volume is reduced and prefrontal cortex of adolescents with comorbid alcohol use and psychiatric disorders. We also know that the cerebellar volumes are much lesser in adolescents who drink in a binge pattern. So this is a study that was a systematic review of over 30 neuroimaging studies, a very impressive one that was published in 2022. I'm going to head straight to SBIRT, which is screening, brief intervention, referral, and treatment. We're all very familiar with the SBIRT model. So we're going to see more in detail. The step 1 of SBIRT is screening. I'm sure that we're all familiar with Odyssey, which is a beautiful screening tool, has very specific questions that helps us identify use disorders. Definition of drinks is the same thing as we saw earlier: 12 ounces of beer, 5 ounces of wine, 1.5 ounces of hard liquor. Odyssey, the first question is, how often do you have an alcohol-containing drink? Never, monthly, 2 to 4 times a month, 2 to 3 times a week, 4 or more times a week. These are very specific questions that you can just use straight out. And I know that AIMS Delhi is now working on validating a Hindi version of Odyssey. They just published their current progress in the language validation. I'm surprised that we still don't have a version of Odyssey or even Cage questionnaires in our local languages in India, but it's important because the language used and the way to use those questions has to be culturally sensitive and has to be adapted, maintaining the fidelity of the test. So that is something that's being worked on, something to look forward to. How many drinks containing alcohol do you have on a typical day when you're drinking? So you've got the scoring there. And how often do you have 5 or more drinks in one occasion? These 3 are your initial screening questionnaires. It should come right off your, this should be used among anyone that's coming in. And we use it here in the emergency rooms or in urgent psychiatric centers. We use it even if they don't come with intoxication, even if they're coming in with just a mental health crisis that they're coming in with. We ask these questions. It's important to ask because it brings in a conversation. You initiate a conversation that could potentially then change, go into a change talk. A scoring more than 3 for women is considered positive, and a scoring more than 4 is considered positive for men. Now, this is the rest of the questions among Odyssey. This is something that you can read at your own convenience, but basically has questions into their specific drinking pattern. And it also very nicely coincides with the Cage questionnaires that we're familiar with, which I will be showing, in a few minutes. Less than 13 is considered to be risky use, and less than 15 is considered to be risky use for men. And anything over that is much high risk drinking, is harmful drinking pattern, and it does require you to provide referrals for treatment program. Patients should receive referral for treatment even at the risky use level, but when their score is towards the harmful use, they must receive referral for services. Now, another approach, which is a quick approach to screening, a quick question: do you sometimes drink beer or wine or other alcoholic beverages? And then that, if they say yes to it, how many times in the past year have you had 5 or more drinks in a day? Or 4 or more for women or men over 65, which is considered to be a positive. And now if they say yes, on average, how many days in a week do you have an alcoholic drink? And how many, on a typical drinking day, how many drinks do you have? So these are very specific questions that we can all ask. This does not require any advanced training for us to ask these questions. These are questions that we can ask even even a layman that's coming to us just wanting help, or someone that you come across who is struggling with alcohol. These are not judgmental questions. You're basically exploring their pattern of drinking. Now, the next 2 is where we start assessing more in detail about their drinking severity. So these, we're very familiar with the Cage questionnaire, I'm sure. C stands for cut down. Have you ever felt that you have to cut down your drinking or drug use? A is annoyed. This is a synonym that you already know. This is an abbreviation. Have people annoyed you by criticizing your drinking or drug use? G stands for feeling guilty. Have you felt bad or guilty? And E stands for eye-opener drink. So easy to remember when you want to ask the severity questions. Cut down. Have you ever thought that you need to cut down? A, do you think people have been annoying you? Does your wife annoy you about your drinking pattern? Does your mother annoy you that you drink a little too much? G, do you feel guilty about your drinking patterns? And E, eye-opener drink. Very familiar, simple abbreviation to remember. Now, going into what a brief intervention actually means. A brief intervention is a very collaborative conversation that enhances a patient's motivation to change their use of alcohol in order to lower the risk for alcohol. Now, very, very important to remember that this is a collaborative conversation. As nurses, we are great in educating patients. We do a wonderful job with educating patients about the harm of alcohol, what alcohol does to your body and mind. We do a wonderful job with it. But it's important for us to reflect, do we do a good job at having collaborative conversations with patients, or do we end up patronizing patients, basically telling them what needs to be done? Now, the reason for change or the reason to create a change in the way we communicate with patients is basically to bring out a shift in internal locus of control. Patients make sustainable change when they have control over that change, when they are the ones making the decision towards that change, when they're the ones taking the measures to change and they're the ones following up on that change. So the goal with a brief intervention is to bring about a collaborative conversation so patients can be empowered to make sustainable change in their patterns of drinking. The focus is on eliciting the patient's own reason for change. We're not the ones telling them you need to change. The patient is the one impressing themselves about the need for change. Now, the practitioner's role, be it a nurse, be it a social worker, be it a psychologist, whoever is working with the patient using this brief intervention, our role is to only guide the patient to develop his or her own plan for change. And we'll see how that is done. Whatever small step the patient is willing to take, that's a win for us. So let's say I would like to maybe explore cutting down 1 drink a week, that's still a win. So it's not about making huge changes. Let them make 1 change at a time, 1 day at a time. And our role is only to facilitate that collaborative conversation. Now, it'll be incomplete to talk about brief intervention without talking about motivational interviewing and stages of change, because they are the fundamental principles and method and everything of a brief intervention. So again, motivational interviewing is a very client-centered style aimed at helping patients people explore and resolve their ambivalence. Ambivalence about substance use and moving through the changes of stage. It revolves around the main 3 principles, which includes expressing empathy, developing discrepancy. This is an interesting concept which we will explore again. What does developing discrepancy mean? Patients have a certain expectation of their own drinking and a certain perception of other people's drinking and what they ought to do, what their goals about drinking should be. So our role is to help patients see the discrepancy of what the ideal that they have set for themselves and what they are actually doing. So in terms of developing that discrepancy and helping people see the discrepancy and work towards reducing that. Rolling with resistance, avoiding argument, big, very important. When you create an argument with a patient, the moment they identify that you have a judgment against their drinking pattern, that you're some way judging them, the possibility is they will shut down very quickly. And then you have lost an opportunity to bring in about, a change in the patient's drinking habits. It's a very directive, client-centered way of interacting with people, exploring and resolving their ambivalence. Okay, so now we'll just quickly see the stages of change, trans-theoretical model proposed by De Clemente and Prochaska. You're all familiar with it if you've learned the trans-theoretical model of change, which starts from pre-contemplation stage all the way to relapse. Now, originally when the model was proposed, it was stopped at maintenance. And then we realized it doesn't end with maintenance because addiction is a disease of relapse. Right? This is a cycle that patients go through, and there is no ending with just maintenance. They go through cycles of relapse. In fact, science shows that people go through at least 7 relapses before they get a good solid handle on the concept of recovery. So when I hear a patient saying, okay, I relapsed, they come back in for sessions and they say, okay, I relapsed yesterday. I had, my ex-wife called. It was too stressful. I couldn't handle all the stress. I ended up going and drinking 7 drinks last night, right? What does that mean for us? Patient has just checked off one relapse. That's it. And then they start the cycle again. So it's important for us to keep that non-judgmental attitude. Relapse is a part of the illness. It's a part of the change process. And if we can help people navigate through that cycle, that's the best we can serve, our patients. So the goal is to create an upward spiral and learn from each relapse. So I don't think I need to go further too much into detail, but like a brief, explanation of what it means to be in pre-contemplation state. I'm not really interested in making a change in the behavior. I don't think there is a problem with my drinking. Yeah, I think I'm drinking just as normal, or just as much as my friends do, or I don't think I'm doing any worse than what my friends are. So here is where we talk about, in social cognitive theory, we talk about normative perception, normative expectancies of alcohol. In young adults, it's important to remember, adolescents more so, and college-going students, if they get into alcohol at a younger age, which they do. The average, start years of getting initiated with alcohol here in the United States is as young as 12 or 13 years of age. And again, it varies among countries. But when they do get started at that young age, they often believe that their friends drink way more than they actually do. So the normative expectancies of alcohol is definitely skewed. So it's important to have that open discussion. What is their expectancy? What do they think their friends drink, right? So creating that discrepancy and talking about change. Contemplation, this is the pre-contemplation is where they're in denial. They don't think there is an issue. Contemplation is they realize that there is an issue, but I don't think I'm ready for an action, right? I don't think I need to really do anything about it. I'm pretty young. I'm okay. I don't think I need, my liver is pretty strong. I don't think I need to make a change. Kind of, that not ready to act face. But they're aware that this is a problem. Now, preparation is where they're starting to realize this is major. I need to start acting on the problem. I do need to address the problem, but I don't know what to do. Right? So that's the preparation phase. This is where we come in. We can start preparing the patient on different things that they can do to bring about lifestyle changes and so on and so forth. And then navigating towards the action phase, where they are actively doing stuff, right? Actively, potentially avoiding parties where there is too much alcohol, different coping skills that they use. There's numerous mobile-based interventions now. In fact, I was just seeing a beautiful app from UK that was about alcohol-free January that they just studied this last year. So different things that are being innovated. So this is where they're actively taking part. They're probably going in for counseling and engaging in AA meetings or different things. Maintenance is sustaining those measures and sustaining in recovery, and inevitably people will go through relapse. And so relapse is identified as the stage before they actually have their drink and ending up drinking, right? It's the state of mind before relapsing into drinking that is identified as that's the phase for us to intervene in. So this is a cycle of change, which we are pretty familiar with, but it was worth reviewing. Okay, so now coming to the steps of brief intervention. We saw what it meant to developing discrepancies, understanding the patient's views on use, not just asking about what do you think is it doing bad for you. It's also important to identify what good is alcohol doing for you, because very often alcohol gives them some good benefits. I mean, people don't do things if it doesn't benefit them in some way. So think about it, right? So they might be making friends when they are, drinking. They might be, they feel that it helps reduce their stress, right? So they have perceived benefits from alcohol when they're drinking. So it's not that it's completely out of benefits from a person's perspective. So it's important for us to ask, and what does this give you when you drink? What are some of the benefits that you notice of drinking? Because that initiates another conversation as to how can we replace those things. So let's say I go to party, I get drunk, I make friends, I don't have inhibitions, I feel like a really fun person to be around. People like being around me when I'm drunk, right? So this is something that we will often hear from young people. that social inhibition, of being in big groups or friend groups and things like that. So they have some benefits to it. So it's important to explore that, right? And then also asking about, what do you enjoy less about using alcohol? And what are some of the regrets that you have about using alcohol? So you're asking pros as well as the cons, not just focusing on the cons. Okay. Now the next step is giving some feedback. So this is where we will come in with the little piece of education. However, going into talking about the risks, you want to make sure that the patient is ready to really hear about the health risks. So I generally ask patients, are you aware of the health risks related to alcohol? If you do, what are some of the things that you are aware of? Commonly, you will hear, oh, alcohol, I know it affects your liver. I know that it's bad for you. So yeah, so I know. So then they may not know the very specific details of what happens to your brain and what happens to different organs and the cancer risk and all those different things. So here's where you use your educational piece of potentially having some kind of an image, like, the one that I showed you earlier. There are excellent resources that pictures speak way more than words. So if you can use a picture-based training, picture-based education, that will definitely start. So I've included in my slides, I've included one of the really useful PDFs from NIDA that shows all the different health risks related to alcohol, and it's copyright free, and you can use that to show the patients. Now the third step is, this is where we get into enhancing the motivation for change. Two important things here. One is readiness for change scale, or simply readiness scale, and the second one is confidence scale. Both are equally important. This is where the real conversation happens. So the question I ask is, on a scale of 0 to 10, how ready are you to make change in your drinking? 10 means I am completely and fully ready to stop drinking. 0 means I'm not ready at all. Usually patients will tell you somewhere around 4 or 5. If someone's super motivated, they see some serious harms from their drinking habit, or their family is really nagging them, you'll hear them say maybe 7 or 8. Whatever number they give you, it's important to acknowledge it. Say, hey, that's great. You have given me 4 or 5. I'm glad that's where you're at. But I'm wondering, what prevented you from telling me 1 or 2? Right? So you're asking them what your reasons for change are. Okay, you're giving them the opportunity to talk about why they feel they need to make the change. And then the next question to ask is, what do you think you need to move that needle over to 7 or 8? So if the patient says, a number lower than 4, then we can ask, what do you need? What is it that you think needs to happen for that number to go higher? So they'll tell you, I can't, I don't have the research. I don't have the coping skills to manage my stress. Let's say that's one of the things. I don't know how to handle my stress. I don't know how to handle my wife, right? So whatever their stress or the reason is, explore that and discussing. And that's where the change talk gets initiated. Now, the confidence scale is similar to what we hear in readiness scale, but you're asking specifically about their confidence. So how confident are you on a scale of 0 to 10 to make these changes? 10, I'm perfectly confident. I know exactly what I need to do. 0, I don't know what what I should be doing. So this also brings in a conversation about the change talk, what methods that they could use to help with these challenges, and so on and so forth. So these two scales are very, very powerful in initiating a change talk. And we all need to get comfortable with talking about the pros as well as the cons, not just the cons. Okay, we're good about educating patients. We know the harms of alcohol. We know to fear our patients. We know how to scare our patients, but scare tactics alone do not work, because they still keep the motivation at the external locus, not at the internal locus. So to bring that internal locus, the patient has to make that decision and see why they need to make the change and really make their plan to change, and you being the facilitator. Now, the fourth step identified in BI is giving advice and negotiating a goal. So you can give advice. We're not preventing providers and nurses and people working with patients. We're not saying don't give advice. We're saying Keep advice to not patronizing the patient. Don't be the one that's jarring the patient with saying you should not drink, that's very harmful, you know, the fear tactics just don't work. So that's not the right way to advise patients. So advising can be about, advising really can be about the harms. We can advise about the harms. We can review what the harms that they identified are, what the things that they didn't know about, you know, the harms caused by alcohol. Those are the advices that we can focus on, and potentially how can we make the changes and what is it that they can use. And here's a good way to also bring about, you know, you can integrate about stress management. You can integrate about trauma. People often go through significant amount of trauma, and they say about 90% of people who are into substance use, including alcohol use disorders, have had adverse life experiences, more than 4 adverse life experiences as a child. So, or in their growing years. So important to consider, you know, trauma in their lives as well. Now, it's important to also summarize, which is a way to reflect that you have captured what the patient has shared with you. Making notes is a good habit. That way you can review the realistic aspects of what the patient has shared with you. Let me summarize what we've been discussing. Is this accurate? Did I miss anything? Anything that you want to add? These are all ways to bring about that collaborative discussion. Now, also important to bring about a plan for follow-up, suggesting, you know, where can we meet next? What, you know, if you are meeting with a patient on a regular basis, if they're at an inpatient unit, if you notice them, you know, if you're seeing them on an outpatient basis, important to create that follow-up plan. You can also provide them resources for referral and other outpatient services, including detox services or AA meetings. I know that there is some, you know, controversy about using AA, you know, research-based activities, but AA still does have a value. Peer-based programs, mentoring programs, different things that are available in your area. So it's important for us to be resourceful as to what programs are available. Also, thank the patient. It's pretty wonderful to have that dialogue with the patient. I often feel like when I've had a solid motivational interviewing, I feel privileged to just have that open conversation about their use pattern and how they can bring about that change. It's a very rewarding experience to use motivational interviewing. And when they leave, patients leave feeling empowered in their own change process. So thanking patient for just taking the time to discuss it and being open, because it can be very difficult to talk about alcohol or other substance use disorders, right? And this is not something that anyone is comfortable discussing, you know, because often people are, uncomfortable talking about it, and their fear of, you know, there's a fear of judgment, the social lack of acceptance, and all the different stuff that goes, the social constructs that goes along with it. So we talk about open-ended questions. ORS is one other important concept while using brief intervention. And I'll tell you, asking open-ended questions is like a meditation for me. It's so easy for us to jump into asking yes or no questions and funneling questions. It has to be a mindful practice for us nurses to practice asking open-ended questions. Simple reason is you ask a person yes or no question, the answer is going to be a yes or a no. Is there a dialogue there? Probably never. And then you have to ask 10 follow-up questions before you can get a good summary. Instead, make it a practice to ask open-ended questions. How do you think alcohol is impacting you? Versus, is alcohol affecting your work? You know, or is your wife yelling at you, nagging at you? Versus asking open-ended question, how do you think alcohol is affecting your family and work life? And that opens up, you know, a more wider space for discussion. Affirmation, statements of appreciation, non-judgmental attitude, and understanding from the nurse with help. It builds open communication and confidence and rapport with the patient. Reflective listening. You are basically there to be a mirror. You're allowing your patients to see what the truth is, right? What the actual drinking patterns are, what the harm from that is, and all the associated things, and what they can do to bring about change. So you are acting as a mirror for the patient to see, and hence reflective listening is an important technique. Summarizing helps reinforce what you have heard, what the patient has shared or the person has shared with us. And it also it works on top of the reflective listening, and it increases the power of reflective listening, and hence it should be succinct. Be a resourceful person. Know what kind of resources exist in your state, in your area of practice, what kind of outpatient treatment services are available, what kind of counseling services are available for people to go in the long run. Do they need detox? If yes, what kind of detox services are available in the locality? Are there inpatient residential programs that you've heard of? So keeping a good resource list is very helpful, and that you can share with the patients. Peer-based support services have their value. AA is one among them. Medication management, I won't go too much into detail of this, but it is important for nurses. We are probably the second most, accessible for patients, right? Like often more accessible than physicians to discuss about what's available. And this is where independent practice comes in. We are able to prescribe here in the United States. We are able to prescribe medications. So I use naltrexone and disulfiram and Vivitrol, which is the injectable version of naltrexone, on a constant basis. So it may not be the case where you are at, and if you don't have the ability, that's not a role that's available in India. But being aware of what medications are available and what it does, educating the patients on the effect of it, what the side effects could be. These are options that you can present to the patient, and that way they can make educated decisions. Now, important to consider the cultural and language adaptation of the screening tools. Like I mentioned before, we don't have a validated Audit C version in Hindi or in other local languages. So when you do use language adaptations, it's important for you to keep the cultural sensitivity of those translations. If possible, I really hope that we do get more adapted languages into Indian languages. I really hope that we create more standardized versions of screening tools. The same thing with motivational interviewing. So these questions that we ask and the way we approach, it might feel different from how we communicate with our patients on a day-to-day basis in different Indian communities. But it is possible. It is possible to have a collaborative, discussion with your patient. So there has to be an attitudinal change from our part, the way we communicate with our patients. And believe it or not, motivational interviewing can be used across the board. It's not limited to only alcohol use. So if you want to talk about medication compliance with patients, talking about just staying on medications, let's say even for hypertension or diabetes management, motivational interviewing has been studied, and there is strong evidence supporting use of motivational interviewing in change talk of any kind. So get yourself, some good training and practice the skills that will make you a strong nurse. Working with adolescents can be definitely challenging because the challenge is around denial, because they don't think there is a problem, or they're not ready to admit that they even drink, right? So rolling with that resistance and bringing about realistic conversations with adolescents. Substance use related information cannot be disclosed withoto specific patient consent. So just because you have a medical consent, if you're in a treatment facility and you can get a medical consent and you have consent to talk to parents, especially in the case of adolescents or young adults, you cannot share substance use information. You do need a separate consent for substance or drug use information. So check with your hospital or facility policies specific to consents relating to substance use disorders. There are strict laws prohibiting sharing of information related to substance use in the United States and many other countries. So check with your local, your hospital and organizational policies with regards to consents about sharing. And that is it for my presentation. And I've also included some references that I used for this presentation, and I welcome any questions that you might have.
Thank you very much, Lakshmi. That was wonderful coverage in the stipulated time, and you finished right on the dot. Thank you so much for that. Now we have a few questions. Compulsive drinking and relationship with trigger.
Yeah, absolutely. I mean, that's a great question. So triggers and compulsive drinking, like I covered through my presentation, people going into relapse or even just drinking episodes are often triggered by stressors, right? Like simple example, I come back from work, too much stress at work, I can't handle the work stress. I come back home, my wife is yelling, there's too much stress about finances. Things trigger people, and alcohol is a relaxant at the lower doses, although it creates impaired cognition in higher doses. It relaxes people when they drink, and then it pattern over a period of time. It develops you develop tolerance, and it becomes an addictive pattern. And yes, it's very much directly correlated with acute triggers and how the pattern of addiction as well as binge drinking develops. So very important to identify triggers. So that is a concept that we discuss within the change talk. What kind of things are triggering you to drinking the way you are drinking right now? And what can we do to change those things? You come back from work, you feel too stressed. Do you think instead of having 5 drinks, can you reduce it to maybe 2 drinks and go for a walk with your kid or with your dog, whatever is relaxing you? Do you think you can replace it with something that is less maladaptive? So important to identify the triggers very much.
Thank you. Another question. After the binge withdrawal, see, after binge drinking, there will be severe hangover, withdrawal, seizures. So some emergency management tips, because many people don't reach the right kind of health facility.
Correct. So when someone is going through acute withdrawal, there are protocols to be followed here, but adapting it to what you would see back home, back in India. If someone comes in acute withdrawal, if it's getting to complicated withdrawals, most definitely they should be brought to an emergency room where they can be given IV fluid replacement, possibly with dextrose in it because their nutrition is often impaired. They might need thiamine and folate replacements. So it is important to bring them, when people start showing signs of acute withdrawal, if they're starting to show, signs of severe dehydration, confusion, those are the complicated withdrawals that you would call it in delirium tremens. Absolutely, an emergency room visit is warranted. If it's an uncomplicated withdrawal, if they're just hungover, hydrating is very important. That's also, recovering from hangover is a really good time to have a change talk. So that could be used as a good window of opportunity. But managing, uncomplicated withdrawals can be done at home, managing with IV fluids, nutrition, providing multivitamins, and so on. But complicated withdrawals, really requires an emergency room visit.
Another question, Lakshmi, is that for binge drinking, people don't come for treatment, and family also doesn't bring them for treatment.
Mm-hmm.
So once they have dependence, then many times family will forcibly take them for treatment. Now, what is the safety of management with medications for binge drinking people?
It is safe to use naltrexone in binge drinking. You're asking specifically about medications, correct? Yeah, so there is a method that we adapt here. People don't like taking medications if it's binge drinking pattern because it's unpredictable. Usually people don't think it's a problem, first of all. However, somehow if you are coming in contact with a patient, somehow they've come in contact with you. It could be because they were brought to the emergency room after an acute incident, or getting into an accident or just complicated withdrawals. They've somehow come into contact with you as a healthcare provider. So this is the opportunity for you to first use brief intervention, making sure that they're motivated to treatment. Using brief intervention is key. Motivation interviewing is key. If they're being forced by family members to come into treatment, it's very possible that they will exit the treatment protocol, treatment program at the same speed that they entered the treatment program. So it's very, very important to identify and use the brief intervention during that time, during that window of opportunity, if you would call it that, to create some internal motivation. When you've been able to do that, and when you are exploring options for medication, as I was mentioning earlier, there is an adapted method of using medications where we call it, here in the United States, is called Sinclair method, where they can use naltrexone right before a predicted binge drinking episode. And that requires immense insight, right? So it's called Sinclair method, basically taking naltrexone before the weekends. let's say someone has a weekend drinking pattern. Friday, done with work, I get out, I start drinking, right? Like I drink entire weekend and then I'm like out. I hungover Monday, Tuesdays, possibly missing work. So if they know that the weekend drinking pattern is what is more harmful, I advise patients to start naltrexone around Thursday. Just start on Thursdays, Thursday, Friday, Saturday, Sunday. Those are your heavy drinking days. You know you're going into a binge drinking episode. Just do naltrexone just those 4 days a week. That's it. If you don't want to take it daily, just know your pattern of drinking. It needs insight. Again, motivation interviewing, advise them to take it only during those binge drinking episodes. And yes, they can drink while on naltrexone, not disulfiram. They cannot drink while they're on disulfiram, obviously because of the reaction that disulfiram gives out. Naltrexone, however, is helpful in that direction because it does not cause an immediate acute reaction from alcohol. It just basically reduces their want and the pleasure that they get from alcohol. So it's possible to use medications while they're in binge drinking mode.
Thank you, Lakshmi. There's somebody asking question. After de-addiction from alcohol, should you advise the person to become social drinker?
That's a very tricky question. Not a tricky question, but it's a tricky area for the patient to navigate, right? So think of alcohol. I mean, alcohol is everywhere. You go to a party, you socialize with your friends, it's everywhere. How can a person just completely exclude their social life, right? So that's a very difficult area for patients to navigate. So this is where we have realistic conversations with them about harm reduction. It's a very triggering thing when someone has been an addict, someone has been a severe alcohol user, going into parties where there is alcohol. It can be a trigger, and it can trigger binge drinking episodes that's super harmful for patients. So this is where we discuss about what's doable and what's not doable. Again, medications can be used to help with those cravings for alcohol where they can cut it down, replacing with non-alcoholic beverages if they can do that. But this is a slow process that needs to be monitored along with the help of a counselor, a therapist that they're working with. It's a very tender area for a patient to navigate because it can go both ways.
Any advice for family members for a person who can't resist to drink?
We talk about cultural factors. Family can be a very strong source of change. They can be strong motivators for change for patients, but it can also become a venue where patients just don't feel comfortable sharing or being honest about their drinking patterns, and they often go behind the family's back and continue doing what they do, especially among young adults, right? Like when they know they can be judged and yelled at, and not having a positive environment where they can share in a meaningful way, it's quite possible that they will turn away from the family and strained family relationships. So my advice to families is to create an open environment where they can talk safely. And instead of just pushing and nagging and pressuring about it, I wish every family can be taught about motivational interviewing. My dream is that motivational interviewing reaches every household, because it is possible to use it, even in
Now the last question before we close, and I give the floor to Dr. Radhakrishnan.
Yeah.
That is the role of law enforcement if they create any public nuisance, because once they have done binge drinking, they can behave in any way they want. We have a case 3 days back in Air India flight, and there's somebody misbehaved with the co-passenger, and something happened, and you see, this is all result of binge drinking because they just can't control their behavior. So what do you suggest for law enforcement in this case?
I mean, safety comes first. If someone's being unsafe, you have to manage safety. You cannot allow for the patient to harm themselves or other people. So safety definitely comes first. Law enforcement has to do what they have to do. Here, what happens is, which is nice, that they don't end up in jail. If someone is intoxicated, they get brought to an urgent psychiatric facility where they can safely get they can go through their withdrawals and come out of their intoxication, and then they go through evaluation process. Which is nice to follow that, and I know that those systems may not exist in every part of the of the world, but law enforcement's role is to enforce the law and to keep people safe, right? So that's their role. Let them do their role, and as our treatment providers. But it's also important for law enforcement to be educated about the harm, what treatment facilities exist, and if there is an urgent psychiatric unit, that they can be brought to for safe management of intoxication. That should be educated, and I think there should be a collaborative conversation between healthcare, people and law enforcement to bring about effective management.
Thank you so much, Lakshmi, for having patience to answer many questions. There are some more, but we can't take more questions. We have to close the session. I request Dr. Radhakrishnan to kindly give us the thoughts on how to thank Lakshmi and Baibi.
Yeah, thank you, Madam Sandhya Gupta. It was well moderated session. Madam, we are really happy that you have taken the initiative and you have called me and said that we are going to have this webinar by January. And you also introduced the speaker and you said that it will be managed. So at the bottom of my heart, my thanks goes to you first and the wonderful speakers. Dr. Jacqueline Bibi, as well as Ms. Lakshmi Nair. It's nice to know that Ms. Nair is from the alumni gang of Nimans. Wherever they are doing good job. And it's nice to interact with you, Madam Lakshmi. And I work in child and adolescent facility as a consultant faculty. So looking forward for some collaborative work in the future. And of course, that's a tender age, as you said, child and adolescent category. And the age of onset for alcohol, it's not only in Western countries, in India also, it's reducing. The children are attempting for alcohol. It was wonderful talk with well-backed PPT, as well as a lot of information. In fact, when I was going through the chat box to get wonderful comments from all. So both the speakers taking time out, and almost 440 people we reached, and they have benefited from this talk. Thank you once again, Jacqueline, as well as Lakshmi Nair. And also thanks are due to our patron, could not make it today. Always he is there, the first person, and till the end he used to be there. Dr. T. Dilip Kumar, the president of Indian Nursing Council, and of course our patron of ISPN. So thank you in your absence. Madam Redama is there always, the pillar of strength and source for all of us. Madam, we sincerely thank for opening up and welcoming the gathering and addressing them. And also we thank all the EC members, including Dr. Nagarajaya, who is there online, and of course, Dr. Ramchandra, the senior 2 faculty members who are guiding us from day one. And all the EC members who have taken pain in creating the group and then communicating them in time. It's a wonderful team effort. I thank all the EC members, Muthu Venkatachalam, Bala Murugan, and Dr. Jayanti, and of course, all the members. And all the lovely participants in the weekend. And we didn't expect this many numbers, but anyway, it shows that they are very keen. And ISPN has, this is the 5th webinar we are conducting. And we do it once in 2 or 3 months, depending on the availability of the speakers. And of course, as Balamurugan mentioned, we do have a national conference coming up in Goa by next month, 24th. Looking forward to get you all there. Madam Dr. Sandhya Gupta, once again, thank you for making it a wonderful program. Dr. Lakshmi,
Thank
nice
you.
to see you. Thank you so much.
Thank
And
you.
good
I
night.
requested,
Have a
I
good
request
weekend.
Dr. Lakshmi if she wants to say something, Lakshmi,
Yeah.
as a last note.
Yeah. Kindly go ahead, Dr. Lakshmi.
I think, Dr. Radhakrishnan, please go ahead. I think you had something else to add.
No, you can again go ahead.
Yeah, I mean, I'm just privileged to be around. I mean, this is wonderful to just sit in front of my teachers, my big four stalwarts of psychiatric nursing, Dr. Redama Madam and Nagarajaya Sir, Ramachandra Sir, Sandhya Gupta Ma'am. I've not been your student, but you've been wonderful in just bringing me to different venues, and I presented at the International Conference on Behavioral Addictions that she had coordinated. So it's definitely been wonderful just being in the presence. Dr. Radhakrishnan, I was in NIMHANS before you joined in, Dr. Jayanti ma'am. So it's just wonderful to be in the presence of my teachers, and it's I'm humbled to just be able to present on my limited experience. You know, I'm not an expert by any means, but being able to practice an advanced role in the United States has definitely exposed me to quite a lot of different things that we could do as nurses. So I'm just happy to be able to share my experience and what I have been able to do in my current practice. So thank you for bringing me, and Dr. Gupta, thank you very much for inviting me again. It's definitely been an honor and a privilege.
Yeah, we're proud of you. We are proud
Do
of
we
you.
have permission to close the webinar? Last word from you, Dr. Edama.
Yeah.
Please
Madam.
unmute. Dr. Edama, please unmute. No, it's not unmuted yet. We can't hear you. Yeah.
Yeah. Lakshmi, I'm so proud of you. And,
Thank you.
and not only that, I feel that my students are really blooming, and all the best for you
Thank you.
to reach the heights.
Thank you very much. I really appreciate
Very
all the
much.
insights that I've learned from you all.
Thank you
Thank
very
you.
much. Have a nice weekend, all of you. Thank you for joining this late evening, because Lakshmi said she has night duty and she can do in the morning. So for her, you have good night now. You can go to sleep, Lakshmi. Thank you, all the participants. Kindly respond to feedback link. So in order to get certificates, I request you to kindly take the link and give us the feedback. Thank you so much for everyone. God bless you. Have a nice weekend. Namaste.
Thank you all. Jai Hind. Namaskar.
Ma'am, thank you all.
Thank you.
Thank you, Dr. Bala.
Thank you, ma'am. So I will end the meeting for all, ma'am.
Yes, please.
Yes, ma'am. Thank you.